During this session, Dr. Naik will explore the transformative potential of AI in nursing, sharing innovative applications that are shaping the future of care, delivery, and research. She will also address critical ethical considerations and the challenges associated with adopting AI in nursing, underscoring the importance of preparing the nursing workforce to embrace these advancements with confidence and competence. Leading this session is Dr. Shanoja, Associate Director and Chief Scientist at the Registered Nurses Association of Ontario. Dr. Shanoja is a visionary leader whose work bridges nursing practice, research, and technology. With a wealth of expertise, she is dedicated to advancing the profession of equipping nurses with the knowledge and tools needed to thrive in a rapidly evolving healthcare landscape. Please join me in welcoming Dr. Shanoja to the stage.
Thank you very much for that introduction. And on the screen, you can see it's only me presenting, but I have a wonderful nurse from William Osler, who is joining with me to share some case stories like how Osler being implemented some of these nursing best practice guidelines. So let me introduce Carla. She is the lead person here at our, William Osler, partnered with the RNAO, Registered Nurses Association, and Carla.
Thank you. Thank you guys for having me.
Thank you. Thank you very much, Carla. So for the next 1 hour, I'm not a clinician person, but I'm more kind of like a data person. But for next 1 hour, I'm going to explain how nurses can contribute in nursing research, as well as why it is required nurses to be, sorry, maybe it's better like I can have a mic because I may be quite loud when I speak. I don't need a mic. Okay, so why there is a dearth in nursing practice that not showing it on the literatures, and why it is important to have nurses to be in forefront of research as well. So the next few slides, I will focus on what we are doing to bring or empower nurses. And as you know, like nurses are also part of the clinic and experience. So everything that we do for nursing empowerment, research, as well as knowledge generation are two key points. Knowledge generation, it could be through research or it could be through any kind of like a quality improvement projects that we do. And I know, William Osler, you do have a quality improvement department itself, but I highly encourage all our nurses and nursing students and people who actually work in this area to generate more publications, more knowledge, because the judgment based on what you do in clinical practice is really important. It's upon your head that need to come in forefront and circulate around with the nursing community as well as around the world. So welcome for the next 1 hour. Wonderful opportunity, how you are generating knowledge and what it contributes back to you in terms of improving your practice and improving the health outcomes of the patients as well. When I say apologies for my language, patients, individuals, and persons all are synonymized, and RNAO highlight equity diversity. So I'm keeping that language as like a synonymized languages. So in today's talk, I'll go a little bit deeper dive in terms of RNAO research unit, what we do, and our best practice guideline program. Some of you were there here in the keynote address Dr. Doris Greenspan gave on day 1. So I'll highlight some of the key points. And then artificial intelligence, the new initiative we started as of 2022, and continue program support based on the best practice guideline. And when I explain some of the acronyms, best practice guidelines, BPG, and best practice spotlight organization, William Osler is a best practice spotlight organization. You can see the banner up there. And nursing quality indicator for reporting and evaluation. This is not a public platform, but a huge, massive data set that we have it in-house, which we use for AI, artificial intelligence project. So this is a unique nursing data system, and we are so privileged to keep it in-house, and we keep the data privacy and ethics for getting the data, and it's not a shared platform and not in public cloud. So I will touch base with each of these key points when I talk about AI, artificial intelligence, but at the same point, why it is important to share the knowledge through the data and importance of developing them. A little bit overview about the research unit. The research unit launched in 2023, last year during the EGM, June, July 2023. Our RNAO has been in the forefront of scholarly article and scholarly institutional activities for the past 20 years. And the best practice guideline program has been there for over 45 or 50 years. And we kind of like come up with a institutional organization. Previously, the research institute was collaborated with one of the universities, and now it's like it's a standalone single entity within the department of IABPG Center. Now, what we ensure is the alignment between the program as well as the alignment with the research that we keep up with the three different objectives. When I say three different objectives, on the left column, you can see at the bottom level, there is the program initiative, where the program initiative focus on guideline development, guideline implementation, and the evaluation. And one of the key points I want to mention is that like in Canada, evaluation is undermined, which is like more generic. Data get like less importance in terms of evaluation. We collect data. The question is like what we do with the data. Now, when the our vision transform care through knowledge locally, nationally, and internationally. With that statement, I want to say all the data that we receive at RNAO is national context, sector-specific context, as well as we have the data that keep it international context as well. One of the highlight is like every organization in acute care or long-term care, they are looking for, okay, what others are doing, how they are proceeding with international context. Are we doing in the same way when European countries, they do a kind of like evidence-based practice. So these data set like that we collect that has rich in context, variety, and volume is a huge data set. On an average, we are getting 10,000 data points monthly and huge reports that we collect from organization biannually and annually. I'll go through the data system and richness a little bit later after defining the program. Within 1 year, where are we in terms of the research unit? We develop a scientific body. The scientific body consists of chairs and co-chairs. They are from national, international and national universities, and some of them are from organizations. We also have institutional eligibility, which is like a huge endeavor, which CAHR approved RNAO to keep as like an institution for holding the funding opportunity. And the third one, that would be really interesting, those who are interested in nursing research, we have an open library. As you know, some of the libraries are really, you have to pay it to university, or you have to get it as a studentship, or you should be a student of a professor, or someone need to connect with you through the user ID and password. So the open source library is really opening up like all the resources for our nursing students and nursing community to investigate a little bit further what they can do and what would be the next level of nursing in terms of like supporting nursing community in care practice. And some of the collaborations are on the left side. We connect with the Amsterdam University. That's a new project started last year and a huge fund received from European Union. And this is a collaborative research. And the next one is through CAHR Institute of Aging, which is another collaborative opportunity, the RNAO research unit we conduct with them. And key innovations are artificial intelligence and machine learning project. And the second one is building the evidence, real world evidence from the practice. That is what I said, whatever you are providing or whatever you are producing from individual organization, they are bringing back to the real world evidence and best practice guidelines. So key role that you all do here as nurses and that you support to the nursing community for future vision. Before I go to the details of the data, I just want to give you a little bit overview about the program. The program was funded as of 1999, and the key focus of the program is to develop, disseminate, and actively support healthcare organizations around the world. Initially, the program was provincial and spread it to nationwide, and now it's like international program. Almost 15 countries and many government sectorials, they directly link with the program where the government themselves keep the program to implement the best practice guideline in every individual organization within that country. So there are different structures of the program. And the second part or the second focus goal is to evaluate the impact of implementing the best practice guideline in different levels. That is like at the personal level and at the organization level and at the health system level. Just to give you an overview, what we produce in terms of developing best practice guidelines. They are classified into different tiers, foundational guidelines. As you know, person and family-centered care is key priority. And then we also have transition in care, which is like a relatively new guideline. And we published one today, which is like a pressure injury guideline. I think like Tiziana was the panel member. I don't remember which guideline she was part of the panel. Tiziana was one of the panel members for a very recent guideline. So pressure injury guideline is like relatively new, published this year, which is like a huge contribution to the community. Now, two key guidelines which I highlight here for acute care setting. One is transition in care guideline, and the second one is digital health guideline. The reason why I highlighted here is like transition in care is a huge topic nationwide and international wide. Are we keeping up with the transition in care when patient or resident move from one place to other place or from one unit to other unit? Now, are we doing nationally across different sectors in the right way? Are we keeping up with the supporting patient and family in transition in care? What are we doing in terms of transitioning when a resident or a person or a single person and family when they move from hospital to home care? So transition in care is like a huge topic. And in acute care setting, the digital health practice and technological interventions are important to kind of like support the interoperability. When I say interoperability, like previous panel also discussed about it, we don't have a common system that at Canada where you can see, okay, this organization is doing this part, whereas the other acute care setting or other hospital nearby that community, are they doing the similar thing for supporting the transition in care? That's an example. But do we have that interoperability of the data sources that support any kind of like intellectual knowledge generation? If we do have, are we sharing it publicly? So those are the key questions that most of the organizations and conferences that came evolved, like how to support data engineers. I don't want to say data engineers specifically, people who actually work in data, how to support, generate all these tools or getting the AI tools on board for bringing it back to the healthcare organization. So something like leaders and healthcare organization need to think, what would be the ethics? I'll go through step by step later, but giving an overview, what we could do in terms of like opening up the data system, or at the same time, on the other side, how can we protect the data that we collect at the personal level? So this is the spread of the program around the world, just like a geospatial map. There is a QR code. You can scan it and see. And the importance of this geospatial map is to identify which organization implemented the guideline, and it's more networking opportunity. Coming to the topic of artificial intelligence, which is like my interesting topic. I might be talking hours and hours on that part if you ask me. So the data has been collected through a secure database, and the secure database in the sense with high privacy and policy in the last 10 years, really a little in the sense we can count number of breaches that had happened. So it's like highly secure. We have security platform where the security platform check the data comes with the utmost security or not. Now, if the data system, actually it's a unique data system only for nursing community, but it's more, the guideline is more at the nursing as well as interprofessional team. So we define it as a nursing data system, but it's more at the forefront of all clinicians and interprofessional team. Most of our data system, as you know, William Osler had implemented FOSS guideline in the past 3 years, and the data system focus on continuous quality improvement. When I say continuous quality improvement, the forefront of the continuous quality improvement is more at the decision making as well as supporting kind of like a resource support, right? And so I want to invite Carla just to give a little bit overview how William Osler used this best practice guideline and inquiry data system for supporting the QI project.
Great, thank you. So making an impact in Falls has been successful because of the leadership and a change team. And of course, the staff has to support these changes as well. And from the guidance from our senior leadership and in the implementation of the RNAO best practice guideline, we've empowered the change team to initiate multiple strategies. And so some of those strategies are our high risk and post-fall protocol. This has been implemented, and it provides a standardized approach to the care, which further supports the increased awareness and knowledge to our staff of the processes. We incorporated our Falls best practice champions, which reinforces the practice just in time, which overall supports that uptake of that best practice guideline. And our champions support our auditing, updating the practices that are occurring right at that bedside. And they provide the education, and they highlight the importance of that Falls. And I say this in my huddles when I've been on units, that the priority of Falls falls down throughout their day. And so the champion helps to bring it back up to that priority list. Education, so I mentioned huddles, so through standardized orientation materials and huddles, and recently we had our Falls exhibit. This highlighted to the staff all the tools that we can use to improve patient safety. So overall, the impact to the patient is that evidence of that knowledge translation to action, okay? And that actioned out reduction in our falls, and most importantly, reduction in harm. So that was really important and should be highlighted. And then I'll talk about a little bit of an experience of a pilot project that occurred in 2022. We were trying to change practice by discouraging the use of 4 side rails. And in that pilot project, staff were, of course, very reluctant. There was a huge change in practice. Everybody's used to putting all of the side rails up. We're protecting our patient. But after providing everyone with education and support, by the end of the pilot, I had staff members come to me and tell me that they were very reluctant at the beginning of that change, but with all that education and support, they saw that at the end of the day, it improved practice and it improved patient care. So that was a very positive change coming out of the implementation of the guideline. Thank you.
Thank you. That is super exciting, Carla. Thank you very much. And this is the exciting moment. I want to say William Osler, how they implemented the best practice guideline. So you can see that the blue line that shows improved false risk screening, which is pretty much closer to 100%. And this is monthly data collection and averaged it out for annual reporting. So it shows like improvements and pretty much getting to 100%. Congratulations. And at the same time, you can see the false outcome, which is like rate of false, which is like a common indicator to measure false in each unit. So it shows a reduction. So the question is like, are they really correlated or associated to each other? Now, from Carla, you heard that other than like two indicators, there are a lot more context we need to add on. So what RNAO does is like collecting these context from organizations. Those are text field based on questionnaire, and my BPSO is the reporting system. And organization have been reporting on three core part. One is practice change, and the second one is what kind of education they provided for staff and person and family as well in long-term care homes, and what kind of policies, because implementing an intervention and bringing that in the context of QI, you need some kind of changes in policy, maybe a revision policy or maybe a new policy that would be developed. Now the question is like, what kind of practice change, organizational changes, and different kind of policy changes that we deal with in organizations. Now, this is a full circle how we get the data on board from different organizations. So best practice spotlight organization, BPSOs, implement the guideline, and it goes through a secure platform, and it passed through a firewall. The firewall is like the security keeping up and checking with the quality and quantity. And Enquire is the nursing data system. And we are bringing that knowledge back to the best practice guideline. So that's the full circle. Now the utilization of the data is like a more decision making and supporting the QI. This is the richness of the data. When you look at the data, it shows like a, I cut it short on the right side, like how the data has been collected over the time, and it shows exponential growth. And many of our data system is from hospital care as well as the long-term care homes here at Ontario. Internationally, more at the acute care, but there are diverse structure because the data comes with the different layers and different tiers. There are programs that host model or individual BPSO model, so we can see different lines of data that are collected. Also, we do have like a hospitals model, which is like a specialty services that Canada, we do have, say, for example, paramedic or some organization, they do referrals only. In Niagara, they do have a long-term care home supportive system. The supportive system is like providing referrals. So also we can see that preventing falls and reducing injury from falls is the largest data set, massive data set we have. And that is the main foci for AI project in these days. Now, key strategies for AI, we need to identify implementation strategies with the largest impact. The question is like, healthcare organization implement an intervention. An intervention could be a broader intervention. Usually the intervention statements are given on best practice guideline. Now, individually, we in the sense organization need to identify what kind of different formatting of implementation of these intervention need to be happened. And that need to be standardized across different organizations. So utilization of these data to identify which intervention is supportive or what could be most impactful to get the best health outcome for patient and health system itself. Now, the second part is utilize the BPSO implementation resources more effectively. So what we do is like more education and awareness. As I said before, Canada-wide or like nationwide evaluation is a part which is like lowered. We collect data in each organization. Say, for example, William Osler, they might have huge database. Are we using that data in the right way? That's the question. So giving more awareness for healthcare organization to utilize the data and bring the knowledge back to the community. And that would be a huge discussion for national and international content. And enhance the knowledge sharing opportunities across sectors. When I say across sectors, even within the acute care setting, I don't know, William Osler, I'm just taking one example, apologize. So William Osler and Humber River Hospital, these are the two hospitals I want to name. Then are you connected to each other? Do you know like whether you can share the data or kind of like people could see what comes commonalities and patterns within your interventions and within your practice? That would be something I defined as like interoperability. It's more technical term, but digital technological advancements support at some point to collect the data easily. I know all of us, like as nurses, we are so busy with the providing care. When you provide care, do you have time to note down just like what kind of data you can collect from the patient at the bedside? Because it's more challenging. You need to get there for providing care. Now, at the same time, if you understand the importance of collecting the data and looking at the data, then that will bring a next level for you because your contribution is really valuable and important for the community. And digital health, sorry, yeah, that's okay. Digital health is something I want to emphasize a little bit more. As of 2022, RNAO initiated a digital health support for long-term care homes and almost like 300 long-term care homes in Ontario. That's a pilot study. They implement evidence-based practice through a third-party digital software, which gives like a more support for organizations in terms of like getting what is an evidence-based practice and how to implement them in a resourceful way. In a resourceful way means like it's more easier because getting the alert on fingertip and saying, okay, this patient need to have like a better support in terms of falls or identified as like a high risk of falls. Now, these type of alerts are directly getting from the digital platforms. I'm not saying AI is the whole world of putting the care in the forefront. Clinical judgment is the main part. One thing I forgot to mention when we develop the best practice guideline, person with the lived experience is part of developing the guideline. And nurses are there in forefront. So the guidelines are developing for you, by you, and getting in the whole community around the world. So to AI perspective, I want to focus a little bit more on advancing the health analytics to AI. To figure out just like AI health analytics, I'm not going in deep details in terms of like health analytics. Previously, it was health analytics getting in platform where we can use as like artificial intelligence. What we do is like, as I said before, interoperability or getting the standardized data on a single platform, which is like a future vision for all of us. And it's like a wonderful opportunity for all people who work in data field. And the second part is data cleaning and integration. As I mentioned before, even when we use the standardized procedure, how much standardization you can do? Can we kind of like collect the data standardized way? But there might be difference because individuals are different. They come with one health issue, or the second person come with different health issues. Each person is individuals are different, and health-wise, health issues are different, or outcome they are expecting from getting the care is different. So the question is like what we need to do is like a real-time monitoring. When I say real-time monitoring, there plays the word of digital health and technologies. So digital health technologies are key. I'm not saying it's going to replace any of the care provided because clinical judgment is a key part of. Sorry, my watch is kind of like bothering me. Give me 1 second. So
when we get collect this data, what we do, we automate a monitoring part, which is like real-time monitoring of the data that we receive, and text analytics. As I said before, any data, if we need to tell the story in a right way, that data has to have some kind of like a context. Previously, Carla mentioned what kind of interventions or multifaceted interventions you use just for implement one intervention or one recommendation from the best practice guideline. Best practice guideline and interventions are more kind of like recommendations are more kind of like umbrella approach, but individually need to identify what kind of procedures in place for supporting the implementation of the intervention. And understanding the organizational context is key. Say, for example, William Osler, what kind of organization are you? Are you a large organization, or you are a medium-sized organization, or what kind of other facilities you provide here? Now, during the keynote address, Dr. Chima mentioned like a new oncology blood testing initiated here at William Osler. But is that in a practice across Canada when you do blood test? Is that actually directly linked to your profile where individual physicians, they get that data? So there is like a gap in data collection, gap in your own health data. All these data matters, and I'm looking forward to see how that data could be linked in different resources, in different ways, and different entities that come in one place for everybody to utilize. I'm saying utilize in the sense utilize and getting back to the practice and improving the practice. It's not utilizing for self-authority, but more kind of like a supporting to clinicians and interprofessional teams to improve their practice. At RNAO, we focus on two key parts when we do artificial intelligence project. One is that we develop our own data quality framework to support our healthcare organizations to maintain the data quality, because high quality data is required for any kind of like AI projects. And the second one is data governance strategy. These are two group of people, group of staff, they are dedicatedly working on with improving the data quality and data governance. We work with healthcare organizations to keep them up. I know like the past 2 to 3 years was a COVID era. I'm not ready to say it's a post-COVID, but still a lot of organizations, they are reporting on the COVID very recently as well. I'm not a person to go there and explain anything, but still we are in the midst of like the same feeling and same way of improving the care. But a huge potential is required to get the data with utmost highest quality to complete any AI intervention, AI projects or any AI tool development. We also have a data quality dashboard and alerting system very recently started to support healthcare organization on board. And these are some key elements that we look at the data quality dashboard, and missingness is like one of the key area that we focus on. Because when organization miss a one data point, it's going to go just like identifying improvements are really out of focus, then getting them on board with the different practices and different quality and data received data system is like a key part for NQUAR. NQUAR is the nursing quality reporting and evaluation. As I said before, data matters. It doesn't matter how you collect and what level of data collection happening. In NQUAR data system, it's a monthly data set, and it collected the aggregated level. So very first time when we initiated the AI project, the question was kind of like what challenges we are going to face. And I'm so proud to say the AI project is innovative. The reason is like we find little to no publication, and RNAO is evidence-based. Whatever we do kind of like a scoping review or literature review. What surprises is like a little to no data that show no literatures published in this area where you can focus on what kind of applicability is there for with respect to the aggregated data that we collect. Now, this is like a roadmap. ongoing security performance, and strengthen the data governance and develop RNAO AI policy were key practice. And where we are at now is like develop the AI tool. And right now, I would say we slow down a bit because of the COVID. In the past, the project initiated before that to develop the AI tool, and we developed it. When we tested it real time, there are fluctuations. There were like previous people, like previous panel were talking about the same, but the issue was a huge turnover. One part I forgot to mention, when we collect the data, we also have headcounts in the sense of how many staff are engaged in implementing the intervention, or how many people are there with respect to nursing staff per person individual. Those are the data that we collect along with the clinical data. Now, a little bit slow down in the sense when you do like automating the data and checking with it, there is like a staggered approach. Actual testing with real time is efficacy rate is a little bit lower now. So we are not coming up with a conclusion. It's getting just like expanded validation test right now. Then within the roadmap at the last line, you can see advanced analytics was the first part. Then advanced analytics we have done, and then move to launching AI innovation. AI innovation is again just like a two-part. One is like supporting our team to reduce their time on investigating more publications that are coming in. And the second one is like, what are some core recommendations that help our nurses to implement the guideline? And the future is like a digital transformation of the AI tool to support nurses in forefront and getting them on fingertips. As I said before, we have conducted a scoping review, and the scoping review is published. You can see some of the reports that came evolved. Finally, we came up with 13 publications only, which is really low. So I highly encourage our nurses and nursing community to build more publications. Even if it is like a small QI project, every projects are not that successful. Even if you think about clinical trials, I'm not saying, I don't know, doctors are here to contradict with me. All clinical trials are not the most successful clinical trials. There are some trials, they are successful. So there are some trials, they show improvements. Now, QI is another way, but could we develop some publications out of the knowledge that you generate or the findings you get it with respect to your QI project? Yes, you can publish them as case stories. So I highly encourage the QI department at William Osler also focus on producing some publications and helping people to come in forefront with the nursing advantages and generation of the knowledge. Now, within the scoping review, which surprises like the most evolved technological advancement or technical intervention is like a regression model. And we also have neural networks, which are more non-clinical aspect. And we also have came up with publications on K nearest neighborhood as like some of the advancements that we can do with the data in order to bring the aggregated data to advanced technology or advanced health analytics. Okay, now I'm going to do with a little bit prototype what we found and where we are at in terms of like generating AI. FOSS guideline is one of the commonly used guideline in our data system. And what we came up is like the most impactful intervention. When I say most impactful intervention, that are based on two databases. One database is the contextual information, and the second one is based on longitudinal data that we collect. And what it came is like the screening. I don't know, Carla, you want to say a little bit more about the screening you have done? Like a screening for FOSS.
Okay. Sure. Here at Osler, we implement our screening through our Schmidt tool, and we capture all admitted patients. And so that tool was implemented in all of the documentation screens, the admission screens, and it's admitted right into the emergency to capture that 100% that you're seeing on your data collection. So those were some of the strategies to screen everybody.
Thank you. Thank you very much. So screening is so effective. And then that is one of the core recommendations that identified from the guideline itself, which is impactful intervention as well. And we have gone through different steps in order to reach there to identify core recommendations from the guideline, which help support improving the health outcomes at the patient level as well as the organization level. Now, what we have done, there are two databases. One is longitudinal data that we collect. And the second one is the MyBPSO, contextual information. And as you know, contextual information matters. So both data system analyzed, which is like more advanced analytics, and all are aggregated. And what we have done is like they grouped into different sectors in order to classify them with the separate interventions and multifaceted approach on implementing the recommendation. Then it came as like a different data points with the text analytics and with the data itself. And that came evolved as like a wonderful journey of kind of like evolving what came nationally, internationally as like best practices, as well as some of the implementation resources that support improving the outcome at the patient level or at the health system level. This is more an algorithm for the text analytics. I'm focusing on the text analytics because longitudinal data is really direct in terms of like getting the AI tool. The reason why I said this is more innovative because it's a combination of text analytics as well as the quantitative data perspective. So two combinations that came evolved, and this is the overall text analytics algorithm that we developed to combine the organizational data that we collected Enquire. And one part I want to emphasize, it's focusing on practice changes, educational changes, as well as policy changes. So when we develop the tool, there would be three interfaces. One is like a, which kind of like a practice changes helping the intervention, multifaceted intervention approach, and what kind of strategies are required to improve it. This is not that fancy slide I created at the last minute. Apologies, but some of the intervention that came evolved throughout like the entire database that was collected from 2015 onwards based on 510 reports. And what came for the false guideline is like a more identifying specific intervention in the sense assessment tool. And you know, like in long-term care homes, poster or here too, poster placing is like another key area we do how to support person and family. Then hurdles, there would be small hurdles or there would be meetings that usually go, and there would be education. And champion is like the one which Carla already mentioned. Those are individual themes and individual key areas that came evolved from all the reports that we analyzed. And rounding is another one. Rounding came as like a different type of rounding. I don't know, we do rounding here as like a main practice.
We do. It's a practice expectation to do our rounding every 1 to 2 hours.
Every 1 to 2 hours, wonderful. So different type of rounding that came evolved is like a purposeful hourly rounding, which is the recommendation from the best practice guideline. And that one was like a really impactful. With one intervention itself, we have seen in long-term care homes, it's highly impactful and health outcomes, reduce a false rate and improved screening for residents and families. And other roundings that came evolved are mandatory safety rounding. And then we also have frequent rounding, which could be deferred with respect to the time. It could be hourly rounding. It could be 2 to 3 hours rounding. And some of the organization, they also mentioned 5-hour rounding when it is like off time in the sense like late night, maybe, I don't know what the context actually, but it's like different time frames and frequency came evolved. So because of the same changes in different aspect of the same intervention, what we have done is like a kind of sector-specific segregation. Sector-specific segregation in the sense long-term care practice may be slightly different from acute care practice. So what we did is, next one. What we did is separate them out into different sectors. So the long-term care practice, you can see when we compare the two overall approach and long-term care approach, some of the practices are more in terms of long-term care homes, whereas the others are more in acute care. Advancing the maturity of the health analytics. What we need to do, as I said before, data need to be get open up. We are here to work on a group of people here to support with developing all the AI tools and advanced analytics. Then the quality performance need to be defined. Then what kind of standards we are getting there, that need to be defined. Are we getting the data in the same way? That's another question. All these key components need to be discussed, not a single entity. And looking forward from William Osler to partner with it and discuss further how to enhance the interoperability between the data system and data we can collect. And the core component, data security features where ethics matters, because are we doing the research or we are doing individual studies within each organization? So ethics is a key for all the research that we do. If it is clinical practice, there is ethics board and ethics committee. But what we do is intervention research. In intervention research is more mixed methods approach or longitudinal study design. Those practices are also required for ethics approval. So the research is key component, ethics is key. And what we do, we all get like a consent, individual consent from healthcare organization before we start the partnership itself. So the consent is with utmost security, and we connect with the people if we want to open up the data system publicly. Looking at the time, continue to program support. I don't know, it's boring a little bit for the clinical group, but I'll quickly go through the next two phase. Continue to support. Yeah, I'll go with the real world evidence is one of the next one. Yeah. Real world evidence is one of the next phase of the project that we are doing, where we generate all this information and bringing it back when the best practice guideline gets renewed. So you are, as nurses, you are contributing back in the community when building the best practice guideline with the new revision cycle. And our best practice guideline are 5-year or 6-year mark for revision and renewal. Next one is the fancier one. I want to highlight this for our William Osler research group. What we are coming up is like just with intervention approach and continuous quality improvement. Next stage for the project is like getting in the research, like actual intervention research. So think about it with the larger department, how to partner that one with the intervention research. And that would be the next focus, to bring it back the same evidence in building the best practice guideline. Yeah, ongoing effort, partnership and collaboration is the key point. Also, we need to know what kind of technological advancements we can build it back to the nursing community. As I said before, digitalization with the alerts for providing care is the key to the next part. So that is coming up with the AI tool. We also looking at enhanced organizational research opportunities, and we are partnering with the different organizations and universities across the countries which we partner with. Lesson learned. Integrated approach, as I said before, just like how to embed the innovation with the practice is key. Are you ready to accept these innovations? It's up to you whether you want to accept it or not. AI tools and health analytics and everything would be there to support you. Clinical judgment is yours, so you need to put your brain when you come in practice, when you see patients and individuals. I don't know. I'm not a person to contradict and not a person to support for this community, especially in terms of the acute care setting. Clinical judgment is important. And throughout the development of AI and bringing the AI into the actual implementation and intervention specific, what we do is like a clinical judgment matters. And we have a huge group of nurses work with us for the AI. And so clinical judgment is there, it's coming up, but something we can work together. And these are some of the publication. A case study was published, as well as an impact intervention was published for AI generation. Then another one is in peer review and accepted, which is like the paradigm between evidence-based practice, which is totally a different area, and the digitalization as well as the AI, which is like on the other side. Both are science-based. Now, the question is like how these two science field, they combine to help the entire community for clinicians and interprofessional team in different and healthcare system. So that's another publication which is accepted very recently, 2 days before. So these are some of the highlights. Thank you.
Thank you so much. I have 2 questions. My first one is I'm just very curious because I'm not a nurse. So Carla, I just honestly want to know, what does rounding look like? I'm just very curious.
Rounding is just going by the patient's room, checking on them, ensuring that they're safe. Like, it's as simple as that. Most of the time it's a dual task. You go in there because you're having to hang an IV. And so you're making sure while you're doing that they're safe. So a lot of it's combined.
Okay, cool. And my second question is, what can we do here at Ori High to make it easier for nurses to start their own research projects?
Wonderful question. The best way, nurses need to talk with the researchers to understand what they could potentially do. My suggestion is that we are here there to support you for the nursing community. It's the Registered Nurses Association of Ontario, and William Osler is already BPSO. So my suggestion is like stepping up and scaling up are 2 key components. Stepping up in the sense, when you do something, even when you provide the care as a nurse, it's the nurse understand the person, individual, nobody else. That knowledge need to build it collectively, as an individual, as a collectively, as well as an organization. Then the step for that one is like be together, work together, and be the betterment for the nurses itself. Generate it as a research project. As I said before, continuous quality improvement, and the next step is research. So build it, since you have a wonderful department here.
Awesome. Thank you. Now we'll take any questions from the group. Oh,
Hi, I know you had mentioned that we could potentially access other organizations' data. I know we haven't been able to do that in past. When would that potentially be a possibility through the RNAO work? I know we'd wanted to do some target setting in past, and it would have been wonderful to see what others were doing. And I'm just curious if you could explain a little bit more about that.
Good question. Data privacy matters, and RNAO is always at the forefront of keeping the security and privacy of the data that we collect. One of the first step that we initiated is the geospatial map. There was a QR code. If you scan it, you get there. What we did is like opening up the database a little bit in terms of which guideline a similar or same organization implemented. Let's say when you go there, you can see, if you're looking at William Osler, you can see how many implementation sites they implemented the guideline on. And it also shows like what kind of actual implementation have done in different organizations around that region. So that is the very first step we are doing. In terms of comparison, I think like even the focus is more generating knowledge at the overall level. As I showed before, just like for acute care setting, this is what it is in general in terms of impactful interventions. When you say impactful intervention in acute care settings, you can streamline and strategize for specific to your organization. That is what I said, just like the organizational size or some of the demographics are important when we look at the aggregated data. The next phase of that one is like a more personal level data collection, which we need to kind of like come up with a cloud iteration. That is the next phase of the AI project. I don't want to go there. We already initiated phase 2, but for the phase 1 is more at the aggregated level data collection. Again, to your point, it would be awesome to get it there, and we will work hard, but I don't have a timeline at this point.
Any other questions?
All good? Excellent. Thank you.
Okay.
Thank you very much for the opportunity.
Thank you.